Welcome, everybody, to EM Journal Foundations. This is a talk where we look at journals and data that has really changed our practice in ED. Today, I want to talk to you about the RECOVER trial for dexamethasone in hospitalized patients with COVID-19, which has really changed the way we treat severe COVID, both in the ED and really changed even throughout my residency. Before we jump into the study, I want you to kind of think back to 2020 before the study came out. This is a New York Times graph of the spikes of COVID. If you look to the left, this was 2020, first spike. You can see just the sheer amount of death that we were experiencing in New York State. And this is way before we had any vaccines and any useful drugs. This is my commute to work. So here we are on the FDR looking westward into Midtown. In front of us is Bellevue Hospital, and at the time we were having so much death that our morgue was full, and we actually had to bring in these kind of mobile refrigerators to act as a overflow morgue. That's the sheer amount of mortality we were dealing with. At the same time, we didn't have great data to support how we should treat this disease. You can see, starting in February, talks of hydroxychloroquine spiked up. People were even drinking bleach. So clinically, we were desperate for some form of strong data to help guide us through this disease. So again, 2020 is when the study actually started occurring. Preliminary data came out at the middle of 2020. Then we saw remdesivir actually, that data came out and we started using that early 2021. And then the full study, which I'm going to talk to, also came out 2021. Again, this is right before we even had any vaccines and right before that second big wave. So as a little background, COVID obviously had a humongous mortality rate in the hospital. And when we looked at early autopsies of people who had died from COVID, we had shown kind of multi-system organ failure. In other diseases, especially inflammatory diseases that cause multi-system organ failure, there had been benefit to giving systemic steroids. But there was limited data on how steroids would affect COVID. And so this was the first randomized control study to look at that. So this study happened in the NHS, the British National Healthcare System, in early 2020. They effectively had a web-based system for a 2-to-1 ratio. 2, proportionally, patients would get kind of the standard care, whatever we were doing for COVID at the time, and 1 would get dexamethasone. And the study criteria looked at 6 milligrams daily for up to 10 days or until discharged. Now, the exclusion criteria was if the hospital isn't having dexamethasone, then you couldn't participate in the study, and 2, if the primary clinician thought dexamethasone was either contraindicated or indicated for that specific patient. So, for example, if someone had COPD and COVID, they would naturally get steroids for their COPD. If there was an exacerbation, that patient would not be included in the trial. This study, unfortunately, was not blinded. And they looked at 3 major outcomes. 1, mortality. Did you live? The amount of time that you were in the hospital, and if you were on a ventilator, how much time you were on that ventilator. And this study was powered to look at a 20% reduction of these differences. So they ultimately had about 11,000 patients recruited. Some hospitals didn't have dexamethasone. Some of them were not suitable for randomization. And this study was actually looking at other meds. So some patients were randomized for those other arms of the different studies. So ultimately, we had 6,000 patients who were randomized, 2,000 in the dexamethasone group, and or the intent to treat for dexamethasone group, and 95% of them actually received dexamethasone. They followed up with 100% of these patients 28 days after discharge. And again, 2-to-1 ratio, so 4,000 patients then received usual care, whatever they were getting in the hospital, but just not dexamethasone. Again, because of the intent to treat, 8% of them actually did get dexamethasone, but 100% were followed up within 28 days as well. So no one dropped out of the study. This is the basic characteristics of both sides. You can see left is dexamethasone, right is usual care. This was, again, a older population, average in the 60s, kind of similar male to female predominance, and most kind of underlying baseline disease was about the same. Just know that the dexamethasone group was slightly older at 67 compared to 66 years of age. Next, they also looked at the ventilatory status of these patients. So overall, about 23% of the patients had no oxygen requirements. The vast majority just needed some form of oxygen, whether it's nasal cannula, face mask, and a minority of these patients, 16%, needed to be on a ventilator. And you can see when you subdivide it into groups, red being the steroid group, green being the usual care, it's about a 1-to-3 ratio, just like kind of everything else in the study. This is the kind of the main data set looking at subdivided people based on oxygen status and whether they got steroids or not. Effectively, everything looks about the same in all groups. So we'll jump a little forward. This is kind of the overall treatments given. Again, there is some overlaps between this trial and some other trials that were testing other drugs. So the majority of these people were just getting corticosteroids, but some people were getting some of these antivirals, hydroxychloroquine, and early remdesivir in like 2 patients here. Let's jump to the major data. We are looking at mortality. The usual care compared to dexamethasone, overall, there was a 17% reduction of mortality from dexamethasone compared to usual care. 22.9% instead of the 25.7%. The confidence interval ranges below 1. So this is a statistically significant reduction. Now, we can subdivide this furthermore into oxygen status, right? So we just talked about the top left, all participants. If you look at people who were ventilated, so B on the top right, there was also a reduction, about a 36% reduction. Again, confidence intervals are definitely below 1, so this was a statistically significant drop for ventilated patients. If we now look to the bottom left, these are patients who are just getting oxygen but not ventilated. This again showed a reduction, 18%. Also, confidence intervals below 1, statistically significant reduction of mortality. More people lived when you gave them dexamethasone than compared to when you didn't. Now, the final one on the bottom right is patients who had no oxygen at all. This was about 1,500 patients. Had COVID, was in the hospital, but they did not need oxygen. And as you can see, off the plain data, there was actually an increase in mortality with dexamethasone. You had more mortality, 17.8% compared to 14% with usual care. Now, the key thing to recognize here is that the confidence interval ranges, the range is under 1 and over 1. So this is not statistically significant. What that says is there's no benefit to giving steroids, in this case as far as mortality, if you did not need oxygen. But if you either needed just oxygen or you were intubated, there was statistical reduction in mortality by giving these folks steroids. Okay? This is, again, looking at that same graph, looking at graphical form. You can see most of the data for ventilated and oxygen only lies on the left side of that line, so suggesting that dexamethasone is better. And for patients who did not need oxygen, you can see it crosses the line, that horizontal line crosses the vertical line, saying that, it may not be significant, but the bulk of the data suggests that perhaps not giving them steroids is a little better. Now they look at some secondary outcomes beyond just the death. So discharge from hospital within 20 days, you see that there is a benefit to dexamethasone, right? You have a higher amount with dexamethasone. As far as invasive mechanical ventilation or the need to get intubated, it's a small number for dexamethasone. So you have a less likely chance of needing intubation. If you look at the bottom, we also have statistical improvement for sensation of invasive mechanical ventilation. That is, can we extubate you? And certainly you had a greater odds if you were given dexamethasone. And then finally, needing renal replacement therapy, so needing some form of dialysis, was less 0.61 in the dexamethasone group compared to usual care. So again, this graph is a little confusing because they're kind of putting both positive and negative outcomes in the same list. But effectively, all the ones that are statistically significant, dexamethasone improved. Finally, there is a quick point in the sub-analysis that really stood out to me, which is days since symptom onset, or how long you've had the disease. So if you looked at patients who had 7 days or less of illness, you can see that right in the middle line, they're pretty equivocal, as in whether you got dexamethasone or not, it's about the same. If you had more than 7 days, then obviously, if you look at the next graph, huge benefit for dexamethasone. So if you were, let's say, day 3 of illness, you've been coughing for 3 days and you ended up in the hospital, dexamethasone might not benefit you. Now, of note, there is no sub-analysis that looked at folks who were less than 7 days with oxygen and less than 7 days without oxygen, but just keep that history in the back. So overall, I think this is a good, strong study, the best study at the time that really randomized folks to getting dexamethasone and not, and showed a true mortality benefit and subdivided the population on who got true benefit and who did not. And this is how I would use it clinically. Okay, so a patient comes in, do you have COVID-19? If not, right, the study didn't look at you. And if so, the first question you have to ask yourself is, do you need oxygen, right? If no, then there's no reason to get dexamethasone. If yes, then I say, how long have you had symptoms for? If you had more than a week, then I'm definitely starting dexamethasone. Again, they use 6 milligrams daily. And if you had it less than a week, well, probably I would start it. And again, the one caveat is that these are patients who did not have either a contraindication or a solid indication to get dexamethasone in the first place. So if someone takes steroids every day, they need it for their chronic inflammatory disease, that is not someone that fits in this equation. They're getting steroids no matter what. Anyways, I hope this journal review was helpful. If you have any questions, leave them below in the comments. Thanks.